Hello everyone, and welcome to discuss a topic about stroke. So in this lecture we will discuss about how to approach a stroke patient, and in another lecture we will discuss the question and answers. So if you're a resident, you're a doctor in hospital, how would you approach the stroke? So first of all, we need to identify. How would you identify? You would identify with the mnemonic FAST: facial dropping, arm weakness, leg weakness, speech difficulty, and time. What is time? Time is equal to brain. The faster you act, the more better for the patient and the more better outcome. So once you have identified and the patient reach hospital, beside doing all the initial management by ABCs while monitoring and doing all the labs here, the next most important step once the patient reaches the hospital is doing a non-contrast CT. Why a non-contrast CT? Because we need to differentiate between a hemorrhagic stroke, that is bleed, and ischemic stroke, that is acute ischemic stroke. For this lecture purposes, we are going to discuss about acute ischemic stroke. Let's suppose the patient developed ischemic stroke. So we have identified, this is our first step. The next most important is knowing the onset of symptoms. So when did the patient develop onset of symptoms? So if the patient developed onset of symptoms less than 4.5 hours and he's in this window and he's eligible means the patient have no contraindications to IV thrombolysis. So our next best step will be IV recombinant TPA. That is tenecteplase in new guidelines 2026, and alteplase can be also used, and with this maximum 25 mg IV bolus once. So that is the most important step. And if the patient is out of the window more than 4.5 or 5 hours, 6 hours later he presented, and less than 24 hours, so then the thrombolysis will not be the choice. So here our choice will be giving the patient aspirin loading dose, and we need to do the CTA and MRA for the head and neck. So once we know the patient is out of the window or patient have done thrombolysis, then next step will always be a CTA or MRA for the head and neck if the patient presents in less than 24 hours. So if it shows a large vessel occlusion, what means by large vessel occlusion? Internal carotid artery, anterior circulation, posterior circulation like basilar artery, and middle cerebral artery of M1 branch. So this is a large vessel occlusion. So if it is a large vessel occlusion and patient presented in less than 24 hours, our next step, the patient is being eligible for mechanical thrombectomy. This will be our next step. But let's suppose the patient did CT-MRA and the large vessel occlusion is not there, means out of these vessels, then the next step will be the secondary prevention. Then the secondary prevention, which includes the BB control, sugar control, the high dose statins, and all other supportive measures. But you should remember, most important step here are these flow charts. So next time when you are faced with the patient, how to approach a patient with stroke, you should have this clear, concise approach in your mind. Thank you.